Welcome to the Deep Dive, where we sift through the information, cut through the noise, and really try to hand you the most impactful insights. Today, we're tackling a health issue that, well, for many people, it feels kind of distant, maybe, until it touches someone they know. Yet it silently affects millions globally, and it actually claims more lives than anything else. It's pervasive, it's serious, and honestly, it's time we truly understood it. Okay, let's unpack this. Our focus for this deep dive is coronary heart disease. You might hear it called CHD or sometimes ischemic heart disease. We've pulled together quite a stack of research, articles, expert notes, trying to give you a clear, concise picture of this global challenge.
And we absolutely need that clarity because the scale of CHD it's just immense. This isn't just a health concern. It is unequivocally the #1 cause of death worldwide.
Wow.
Think about that for a moment. Historically, back at the dawn of the 20th century, cardiovascular diseases, CVDs, they accounted for less than 10% of global deaths. But by 2001, that figure had already surged to 30%. Fast forward to 2019, and nearly 18 million people died from CVDs.
Yeah.
That's 32% of all global deaths.
32%.
Exactly. And a staggering 7.4 million of those deaths were specifically due to coronary heart disease.
Yeah.
It's a profound shift in just over a century.
It truly is a colossal change. So our mission today really is to understand why this disease has become so prevalent, what specific factors are at play, and crucially, what actionable steps we and, global health systems can actually take for its prevention and control. This deep dive is about equipping you with essential knowledge, not just to be well-informed, but maybe to foster a deeper personal understanding of, well, one of humanity's biggest health challenges. When we talk about these staggering numbers, it's important to remember that the burden isn't evenly distributed across the globe, is it?
Not at all.
A heartbreaking 82% of all CVD deaths actually occur in low and middle income countries.
Yeah, that's right.
And this often boils down to a critical issue, a profound lack of access to integrated primary health care. So early detection, prevention, it just doesn't happen for too many people.
Exactly. And if we look for a powerful case study, India really stands out dramatically.
Yeah.
The country is experiencing what experts call a rapid epidemiological transition.
Okay, what does that mean exactly?
Well, it means it's shifting from primarily dealing with infectious diseases, like TB or malaria, to confronting this massive rise in non-communicable diseases, NCDs, and that includes CHD. Back in 2005, CVDs accounted for over 53% of all deaths and a massive 44% of disability-adjusted life years lost.
Right, daily journalists. That's the measure of healthy life lost, isn't it?
Precisely. It helps grasp the sheer scale of a disease's impact beyond just death. And by 2016, NCDs were responsible for 60% of all deaths in India.
60%?
Yeah. And to put it into even sharper relief, India alone accounts for more than 2/3 of the total NCD deaths in the entire WHO Southeast Asia region. In 2016, a heartbreaking 1.6 million people died of CHD in India. Just staggering numbers.
That truly emphasizes the concentrated impact in certain regions. It paints a very clear picture of the human cost. So it's certainly not a single villain behind this global killer, is it? It sounds like a whole cast of characters working together.
That's a perfect way to put it.
That's a crucial insight, the multifactorial nature of CHD.
Precisely. The truth is, CHD isn't caused by just one thing. Its etiology, or its origin, is multifactorial. That means it results from a complex combination of multiple interacting causes, not just a single agent. And we broadly categorize these into two groups: factors that are largely non-modifiable things beyond our direct control, and then, crucially, those that are modifiable.
Okay, let's start with the non-modifiable ones first, the things we can't really change. So these are aspects like age, right? Advancing age is a clear risk. Then sex. While it affects both, males generally have a higher risk, though I think some sources mention higher morbidity, like illness rates, for females.
Yeah, there's some nuance there, but generally higher death rates for males are often cited. Family history also plays a significant role. If, your close relatives have a history of CHD, especially early death from it, your risk increases.
Right.
And finally, genetic factors. We know our genes can predispose us, influencing things like cholesterol levels.
So these are the cards we're dealt, basically.
Indeed, those are the cards we're dealt. But what's truly empowering, and what we really want you to take away today, is that many of the other cards are entirely within your hand. This is where we pivot to the crucial category, the modifiable risk factors, These are the areas where you can make a significant, tangible difference.
And these are powerful levers. Let's start with tobacco use, especially smoking. Our sources label it as the single largest cause of preventable death globally.
Absolutely critical point.
Mhm.
Preventable.
Yeah. Smoking actively fuels atherogenesis. That's the hardening and narrowing of your arteries. And it can lead to sudden, fatal heart events, particularly in men under 50. And what's more, it has this synergistic effect, right? Meaning it doesn't just damage on its own, it works with other risks like high blood pressure and high cholesterol to amplify the destruction.
Exactly. It multiplies the danger.
So here's the crucial positive bit, the aha moment, maybe. A real beacon of hope. The risk decreases substantially within just 1 year of quitting.
It's incredible, isn't it? The body starts healing almost immediately.
That's an amazing return on effort. Okay, next up, maybe the silent killer. Hypertension or high blood pressure.
Yes. This is considered the strongest risk factor for ischemic heart disease. Strongest.
Wow.
And think about this. Even a small silent increase in your blood pressure, say just 10 points diastolic or 20 points systolic, it doubles your cardiovascular disease risk.
Doubles just from that small increase.
Doubles it. It's a powerful reminder that every little bit matters in managing this. And often, the systolic pressure, the top number, is seen as a better predictor.
Good to know.
Then we have dyslipidemia. Sounds technical, but it's essentially an imbalance in your blood fats.
Like cholesterol.
Exactly.
Huh.
High levels of LDL cholesterol, the bad cholesterol, are directly linked to CHD, while HDL cholesterol, the good kind, actually offers protection. The recommendation for adults over 20 is to get screened for blood lipids every 5 years or so. And we know that a mean serum cholesterol level above 200 mg/dL is associated with high risk.
Okay, 5 years. That's a good benchmark.
And another significant one, diabetes mellitus. Diabetes increases the risk of CHD by a staggering 2 to 3 times.
2 to 3 times.
Yeah. And sadly, around half of all diabetic patients eventually die from atherosclerosis, that artery hardening and its complications. This is especially poignant in places like India, where type 2 diabetes has really become an epidemic, fueled by an aging population and while rapidly rising obesity rates.
Which brings us to obesity itself.
Right. A major risk factor for heart disease, stroke, and diabetes. The famous Framingham Heart Study, which I know we'll talk more about,
Definitely.
found a dramatic increase in sudden death among men who are more than 20% overweight.
Dramatic increase. Wow. And often tying up with these, we have physical inactivity and an unhealthy diet, right?
Absolutely intertwined.
Mhm.
Diets consistently high in saturated fat, refined carbs, think white bread, sugary drinks, and low in fruits, vegetables, and beneficial fish oils. They contribute significantly.
And we shouldn't forget psychosocial stress either. Our sources definitely acknowledge that as another genuine risk factor. It's a powerful reminder that our mental well-being really impacts our physical health.
It really does. And what's truly fascinating here, or maybe concerning, is the long game. Many of these modifiable risk factors are actually planted way back in childhood and adolescence.
How so?
Well, think about the habits we form early on. Regularly consuming refined carbs found in candy and soft drinks, or maybe starting smoking or drinking alcohol. It really makes you think about, those habits from when you were younger. The long shadow those early, seemingly innocent choices can cast.
Yeah.
This raises a really important question. How much more impactful would prevention be if we focus more intensely on these early life habits?
That's a profound thought, and it leads us naturally to understanding that prevention isn't just one thing, is it? It's a multi-layered strategy.
That's exactly.
So let's dive into these different levels of prevention.
Absolutely. We categorize prevention efforts into primordial, primary, secondary, and tertiary. Primordial prevention is really the purest form. It aims to prevent risk factors from ever emerging in the first place.
Before they even start.
Yeah, exactly. For CHD, this means things like avoiding starting smoking or consistently choosing fresh whole foods over fast foods, colas, candies. It's about preserving traditional, healthy food habits and fostering an environment where those choices are easy. Schools, for instance, play a crucial role here. For preventing hypertension specifically, it involves maintaining a normal body weight through healthy nutrition and regular exercise, and avoiding those super sweet foods from an early age. It's about building healthy foundations from day one.
Makes sense. Building the foundation.
Then we move to primary prevention. This involves action taken before the onset of disease to prevent it occurring at all. This level often has two facets. First, health promotion, which strengthens overall well-being through things like health education, maybe environmental changes, nutritional interventions, lifestyle changes. And then there's specific protection, which targets particular diseases. For CHD, this includes promoting that prudent diet we'll talk more about, advocating for quitting smoking and avoiding excessive alcohol, offering strategies for stress control, and managing existing hypertension. Regular screening for hypertension, high cholesterol, and diabetes is also vital here. Remember that recommendation. Every 5 years for adults over 20.
So if we're looking at primary prevention on a larger scale, like for a whole country, are there different approaches? How does, say, the WHO advise governments? Is it about everyone or just high-risk people?
That's a great question because the WHO recommends two distinct yet complementary strategies. There's the population mass strategy. This is directed at the entire population. The goal isn't just to help a few individuals, but to subtly shift the whole risk factor distribution in a population towards healthier norms.
Like moving the average.
Exactly. This involves large-scale community mobilization,
Right.
focusing on nationwide dietary changes, broad smoking cessation campaigns, maybe reducing salt across the food supply. It's about changing the environment. The other approach is the high-risk strategy. This identifies individuals who are already at elevated risk and provides them with specific advice or interventions tailored to their needs.
More targeted.
Right. While it's highly effective for those specific individuals, the high-risk strategy alone might not reduce overall disease rates in the general population as much as the broader population strategy might. Both are vital, but they serve different purposes.
Okay, that makes sense. Two different tools.
Then moving on, secondary prevention aims to halt the progress of a disease at its very early or incipient stage and prevent complications. This relies heavily on early diagnosis and prompt treatment.
Catching it early.
Precisely. For CHD, this continues to include regular screening and medical management of conditions like hypertension, high cholesterol, and diabetes. But for individuals who already have established CVD, secondary prevention involves critical drug therapies. Things like beta blockers to slow heart rate, ACE inhibitors to relax blood vessels, and statins to lower cholesterol.
Right, common medications.
Very common and very effective. These, combined with quitting smoking, are absolutely crucial tools in preventing repeat heart attacks or strokes. Finally, tertiary prevention. This focuses on reducing the impact of long-term disease or disability, minimizing suffering in the later stages.
Managing the long haul.
Exactly. Examples here include lifelong medications, maybe beta blockers, aspirin complex procedures like angioplasty to open arteries, and essential rehabilitation services to improve quality of life after a heart event.
So we have these layers: primordial, primary, secondary, tertiary. What does this mean for real-world application? How are these strategies actually being put into practice, especially in places like India that face such a huge burden?
Well, what's fascinating is how India, recognizing that many non-communicable diseases share common risk factors, is implementing a truly integrated approach. They developed the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke. It's a mouthful, so it's called NPCDCS.
NTCDCS, got it.
This program was really born out of necessity because their existing health system was mainly geared towards infectious diseases, so they needed to adapt quickly to this rising tide of NCDs. It's a really powerful case study in strategic adaptation.
So it covers multiple diseases at once. What are some of the key pillars or practical things this program actually does on the ground?
It's incredibly multifaceted. On the health promotion side, they use massive health education and mass media campaigns. They champion healthy lifestyles, even including traditional practices like yoga, and promote healthy eating.
Okay, raising awareness.
Yes, and a practical cornerstone is opportunistic screening. So people age 30 and above get routinely checked for diabetes, hypertension, and common cancers like oral, breast, cervical cancer,
Yeah.
often using simple strip tests for blood glucose right at the community sub-centers. Very accessible.
That makes sense, catching things where people are.
Exactly. They've also set up specialized NCD clinics at community health centers and district levels for diagnosis and ongoing management. Plus, the program emphasizes developing trained manpower, making sure doctors, paramedics, nursing staff are actually equipped to manage NCDs effectively.
Training is key.
Absolutely. Beyond that, there's a clear system for referral and management. Regular patient checkups and complicated cases get referred to district hospitals, which even provide home-based palliative care in some cases. They're also promoting community empowerment, trying to involve the public directly in prevention efforts. And interestingly, they're ensuring integration with traditional medicine systems like AYUSH, that's Ayurveda, Yoga, Unani, Siddha, and homeopathy, and even linking with existing TB control programs.
Wow, that sounds incredibly comprehensive, integrating traditional and modern medicine, community involvement.
Really is trying to tackle it from multiple angles.
And it's clear India is taking this fight seriously, not just with programs, but by setting really ambitious goals. They've aligned their national efforts with global targets, like under the WHO Global Action Plan for NCDs. For example, they're aiming to significantly reduce premature mortality from CVD, cancer, diabetes, chronic respiratory diseases by 2025. That's a huge goal.
A massive goal.
And crucially, they're aiming to halt the alarming rise of diabetes and obesity. I mean, think about the impact of just significantly reducing tobacco use or ensuring a large portion of eligible people get preventative drug therapy and counseling. These aren't just abstract numbers. They represent millions of lives potentially saved or improved.
Absolutely. And what's truly striking here is how these ambitious targets reflect not just a strategic, integrated approach to tackling NCDs head-on, but they also underscore the immense, ongoing challenge these diseases represent. It's a massive undertaking, but one that definitely provides valuable lessons for other nations grappling with similar health burdens.
Definitely. Okay, shifting our focus a bit now to one specific and incredibly impactful modifiable factor. Let's talk about diet.
Yes.
Our sources highlight its role as, well, nothing short of the principal preventive strategy for CHD. It's not just a recommendation. It sounds like it's foundational.
Absolutely foundational. The WHO has laid out a series of recommended dietary changes, often called a prudent diet, which gives really actionable advice for drastically reducing CHD risk.
Okay, what does a prudent diet look like?
Well, the core idea is pretty straightforward. Drastically cut down on saturated fats. Aim for less than 10%, maybe even less than 7% of your total energy intake from them.
Less saturated fat, got it.
You also want to reduce dietary cholesterol, ideally below 200 milligrams per day. And crucially, the recommendation is to significantly increase complex carbohydrate consumption.
So that's like cruel.
Think vegetables, fruits, whole grains, legumes, beans, lentils. Getting enough of these reduces not just CVD risk, but some cancer risks too.
Okay, more plants, more fiber.
Exactly. Reducing salt intake is also vital, aiming for 5 grams daily or less. High salt intake directly contributes to high blood pressure and CVD risk.
5 grams. It's about a teaspoon, right? Seems tough with processed foods.
It is tough, requires real awareness. The prudent diet also recommends the avoidance of alcohol consumption and, critically, maintaining a normal body weight. That means a BMI within the 18.5 to 24.9 range and actively preventing weight gain over time. Easier said than done for many of us I know, myself included, but vital advice nonetheless.
Indeed. And this isn't just about what not to eat, is it? It's more a holistic approach, building health through mindful food choices day in, day out.
Precise.
And it's particularly relevant because, unfortunately, unhealthy diets are rapidly becoming more common in lower resource settings, adding yet another layer to this whole global burden.
That's a very worrying trend.
Now, to really understand much of what we know about CHD today, we absolutely have to talk about a foundational piece of research, a study that truly shaped our understanding. Let me introduce you to the Framingham Heart Study. This is a classical example of what's called a cohort study. That's where researchers track a large group of people over many, many years, observing their habits, their health outcomes, to see how different factors affect their health down the line. And here's where it gets really interesting. This is the study that pretty much revolutionized our modern approach to heart health.
The Framingham Heart Study truly was a game changer, no question. It was initiated way back in 1948 by the United States Public Health Service, and it had a clear, ambitious purpose to study the relationship of various factors, things like serum cholesterol, blood pressure, weight, smoking habits, to the subsequent development of cardiovascular disease.
So they were looking for connections.
Exactly. And given how slowly heart disease can progress, the study was initially planned for 20 years. It involved 6,507 residents aged 30 to 59 from the town of Framingham, Massachusetts. They underwent biennial examinations, that's every 2 years, gathering incredibly extensive, detailed information over decades.
Wow. Biennial exams for decades. That's a huge commitment from the participants.
Incredible commitment.
So after all that meticulous data collection, what were its most significant findings? What did we learn that truly changed how we think about heart health today? How has it influenced our daily lives, really?
Well, the discoveries from Framingham are now things we almost take for granted, common knowledge. But at the time, they were absolutely groundbreaking. The study unequivocally found an increasing risk of CHD with advancing age and confirmed it was more frequently seen in males.
Okay, age and sex confirmed.
Right. It definitively showed that hypertension, high blood pressure, and elevated blood cholesterol levels are strongly associated with a greater risk of CHD. No question. They also established that tobacco smoking and habitual alcohol use significantly increase the risk.
Smoking and alcohol, clear links.
Clear links. On the positive side, the study highlighted that increased physical activity was associated with a decrease in CHD development.
Good news for exercise.
Definitely. It confirmed that increased body weight predisposes people to CHD and that diabetes mellitus increases the risk significantly. And one particularly interesting finding was that smoking seemed more strongly associated with sudden death from CHD than with less fatal forms of the disease.
That's a chilling detail.
It is. And we connect this to the bigger picture.
Yeah.
Well, the Framingham study basically became the prototype for countless similar cohort studies all around the world. It immensely contributed to our understanding of this multifactorial causation idea and identifying risk factors for chronic diseases in general, not just heart disease. It fundamentally shifted how we view and prevent heart disease.
A true landmark. So, beyond the individual stories and incredible research like Framingham, how do experts actually measure the impact and prevalence of a disease like CHD? How do they grasp its burden on a whole population?
Yeah, to gauge the true burden, we use various epidemiological measures. The proportional mortality rate, PMR, is one of the simplest. It's just the proportion of all deaths in a population that are attributed to a specific disease.
Okay, what percentage die from it?
Exactly. For CHD, it accounts for a significant chunk, maybe 25–30% of all deaths in most industrialized countries. We also look at the incidence rate, which is the number of new cases occurring over a period. Though for CHD, this can be tricky to measure perfectly, so sometimes mortality rates are used as a rough indicator of incidence.
Right, because not all cases are fatal immediately.
Precisely. And then there's the prevalence rate. This estimates the existing cases both old and new in a population at a specific point in time. For example, some studies from the 90s up to 2002 showed a pooled prevalence of about 6.4% in urban India versus only 2.5% in rural areas, highlighting those regional disparities again.
Urban versus rural difference. Interesting.
Yeah. And beyond these main ones, we also consider things like age-specific death rates, measuring the levels of various risk factors circulating in the community, and even assessing the general availability and quality of medical care. All these pieces help build the full picture.
And it all seems to loop back to that immense human cost, doesn't it? Especially in those low and middle income countries where, as you said, 82% of CVD deaths occur. That lack of access to integrated primary health care for early detection, it just leads to these premature deaths, tragically cutting lives short during people's most productive years.
This is historic reality.
We've covered such a vast landscape today on this deep dive into coronary heart disease. I mean, from understanding its immense global burden, the #1 cause of death worldwide, to really dissecting that intricate web of risk factors, both the ones we can't change and, crucially, the ones we can.
Yeah, the modifiable ones are key.
Exactly. We've explored the different levels of prevention, from primordial efforts way back at the beginning, stopping risk factors ever emerging, right through to tertiary care for long-term management. We looked at India's proactive and integrated national program, NPCDCS, as a really powerful case study. We drilled down into the foundational role of that prudent diet, and we've truly appreciated the legacy of landmark research like the Framingham Heart Study, which, as you said, fundamentally shaped our understanding of heart health.
That's right. And I think the core message really is that while coronary heart disease presents this significant global challenge, truly understanding its multifactorial nature and these various levels of prevention, well, it empowers not just healthcare systems, but you as an individual.
Absolutely.
Knowledge is always most valuable when it's understood and then applied, isn't it? There's always more to learn, of course, and multiple perspectives truly enrich our understanding, hopefully giving us a clearer path forward.
Absolutely. So maybe as you go about your day, here's a final thought. Consider how the historical rise of CHD, from being a relatively minor cause of death just over a century ago to becoming the world's #1 killer, how that reflects these profound societal shifts, changes in lifestyle, diet, even those childhood habits we talked about. What further changes do you think are needed, both globally and perhaps personally, to start reversing this alarming trend and better protect future generations? Something to mull over. Thank you for joining us on this deep dive.